The transition from fetal to neonatal life requires knowledge of the structures and the adaptations that have occurred in fetal life, which you'll remember. The objectives here are to first remind yourself of the fetal circulation and just follow a red cell through the fetal and then the neonatal circulation to determine what happens when the shunts that are available to the fetus disappear. And then to explain the reasons why the pulmonary vascular bed dilates and contracts. Identify the remnants of the fetal shunts. Those are questions that are asked frequently. Remnants of the fetal shunts are the ligaments that are left over in adult life. And then describe the pathophysiology of the persistence of fetal circulation. This is a pathologic situation, a pathologic condition of the fetus whereby some of those shunts don't close and the usual resistance in the different vascular beds don't completely make the transition. You can use any diagram of the fetal circulation and then follow that red cell from, let's say, the right atrium, then through the circulation. It's in serial, so you have to take a couple blood cells to take it through. And understand on the way the oxygen concentrations that exist within the various spaces based on the fact that if there's a lower oxygenation drained bed that contributes to a higher oxygenation, it's going to be somewhere in between. You certainly don't have to know the exact PO2s, just a general feeling for where there's mixed blood and where there's a blood that's not mixed from the shunts. Remember, the fetus lives in an aqueous environment, doesn't have to breathe air. But at birth, gas exchange has to be transferred from the placenta to the lungs. I mean, the gas exchange function has to transfer from what's occurring in the placenta to what's occurring in the lungs. And the fetal circulatory shunts do have to close. And importantly, the left ventricular outflow must increase. Umbilical vessels change because they're reactive and they react in response to an increase in the blood PO2 augmented by the external clamping of the cord. The umbilical vessels I'm referring to are the two umbilical arteries and the umbilical vein. The umbilical vessels are, of course, unnecessary once the placenta is not the main gas, GI, renal organ of the fetus. What happens in the ductus venosus? When the placental circulation is removed, there's a dramatic reduction in that blood flow back towards the heart. Remember, the ductus venosus is a precardiac blood vessel, and it carries blood from the placenta, highly oxygenated, the most oxygenated blood from the placenta directly into the right atrium. Now, in your embryology books, it's artist's conception of where those blood vessels actually are, but in fact, the shunt that goes from the umbilical vein to the atrium is a direct shunt from the vein to the atrium. In your embryology texts, it looks like it enters into the superior vena cava, but in fact, the bottom part of the right atrium has multiple entries from multiple veins. The hepatic veins enter into the bottom of the right atrium, the IVC enters into the bottom of the right atrium, and the ductus venosus enters right into the bottom of the right atrium. They don't enter into the IVC before it reaches the right atrium. That's just an artist's conception. With the dramatic fall in that blood supply to the heart, there's a closure of that duct because it is surrounded by musculature that is normally tonic but has blood flow going through it. And at this point, when there's no blood flow going through, the muscular walls of that ductus venosus clamp off. And this happens over the course of time, about 3 to 10 days after birth. What changes in the lungs? During gestation, there is a gradual reduction in the pulmonary vascular resistance, but mostly it's a high vascular resistance. At birth, there's an expansion of the lungs. We want them to expand. We want the baby to take that first breath. We actually stimulate the baby pretty vigorously to take that first breath. And with the expansion of the lungs and the drop in the diaphragm, space is created in those blood vessels. And the blood vessels are held open by that lung expansion. The resistance dramatically falls, and the blood flow, instead of going to the systemic circulation through the ductus arteriosus, they branch more fully into the right and left pulmonary artery that feeds that now low resistant circuit. Pulmonary blood flow is dramatically increased. Remember, better oxygenated blood also reverses the pulmonary vascular resistance. And the pulmonary vascular resistance is stimulated by hypoxia, and therefore, when there's less hypoxia, the vascular resistance goes down. The inflow into the pulmonary circulation then increases the backflow, the venous return into the left atrium. And that automatically begins to increase the preload, begins to increase the load in that left ventricle, to which the ventricle responds. So it happens in the heart. There's decrease in IVC flow, as it's described as the ductus closes. And there's a fall in that venous return to the right atrium subsequently. In that manner, the right side and the left side circulations, the right side atrium, left side atrium begin to equilibrate, and their pressures become more equal. The cardiac output is tightly linked to what's needed by the neonate and by the fetus. Oxygen consumption, of course, demands a certain cardiac output per gram of tissue. There are metabolic demands. There are demands of an increased need for thermogenesis. And due to that, the work of breathing and due to the extra caloric utilization that requires a higher metabolic rate, there's a new need for more oxygen per gram of tissue. The term fetus has a combined ventricular output. Remember, in the fetus, the blood is actually in parallel in the heart. In our blood supply, and in the neonate, it converts to a serial circuit. And remember, each ventricle, therefore, has a demand on it to increase its cardiac output, double its cardiac output. The ventricle in utero doesn't respond extremely well to an increase in the stretch. So on the Starling curve, it's operating pretty much at the top. As the neonate becomes more oxygenated, there's a better ability for that cardiac tissue to respond to the demands that come from increasing vascular resistance in the overall fetus, decreasing vascular resistance in the pulmonary circulation, that changes blood volumes, and the ventricles respond well along that Starling curve, better than a fetus responds. As the switch from fetal hemoglobin to adult hemoglobin occurs, there's less of a strain on the heart to produce that high cardiac output, to deliver that oxygen per gram of tissue. because the adult hemoglobin, of course, can carry and deliver more oxygen more efficiently, the hemoglobin A. That allows the heart to drop its cardiac output over a period of time in that neonatal life. There are abnormal circumstances that can result in this transition from fetal to neonatal life to either not occur or to actually revert to fetal life. That's called persistence of the fetal circulation, or actually regression to the fetal circulation sometimes. In the neonate, pulmonary arterioles are still very reactive, and they do respond. They respond to hypoxia, hypercarbia, acidosis, and cold. And those arterioles will constrict in response to those factors. That then changes the pulmonary vascular resistance. This is the typical situation in the fetus. That's why it's called persistence of the fetal circulation. When that pulmonary vascular resistance in the right side, pulmonary vascular resistance that the right side of the heart sees now, because it's looking at the pulmonary circulation, when that goes up, there's a favored shunting from right to left, or a tendency towards shunting from right to left, meaning low oxygenation to higher oxygenation across the femoral valley sometimes, depending on the size of it, and across the ductus arteriosus. Neither of these are completely closed at the beginning of that transition. And therefore, there's a reversion or a persistence of that fetal circulation. There's one major difference. So let me just go back to explain the pathophysiology. These are adverse circumstances, the return to this fetal circulation. And the conditions that can occur in the fetus that can result in this adverse circumstance, the adverse circumstance being low PO2 and therefore low oxygen sats, and acidosis, acidemia that occurs, and an accumulation of CO2. In the fetus, when there's a limitation of its blood supply, when there's uteroplacental insufficiency, the fetus does develop these lower PO2s and does develop this relative acidemia in the abnormal situation. And when that occurs, that pulmonary vascular resistance stays high. In addition, there's a response in the gut. There's a stress response, and the fetus evacuates the bowel contents, the meconium it's called, and those bowel contents are irritants. They are circulated through in the fetal lung circulation. What I mean is the fetus actually inhales, exhales the amniotic fluid normally. And when that occurs, then there's an irritant in the amniotic fluid, why an inflammatory response is set up, which again liberates those products that irritate, that cause vasoconstriction, that are the components of the typical inflammatory response, again exacerbating that rise in the pulmonary vascular resistance. There are other circumstances, even at delivery. So there's three things. Either the fetus has uteroplacental insufficiency that results in a low PO2 and the subsequent hypoxia and acidemia and hypercarbia. There can be a circumstance of the meconium that's the inflammatory response that can irritate the pulmonary vascular resistance and cause a persistence of that normal fetal vascular resistance in the neonate. And then an occurrence at birth of a delay in delivery of the body after the head already comes out, called shoulder dystocia, can occur. A baby can get profound hypoxemia, profound hypercarbia, and this is another typical condition that results in a persistence of that high pulmonary vascular resistance and the persistence of those shunts and a persistent fetal circulation. When those shunts are apparent, there can be right to left shunting, meaning low oxygen blood to higher oxygen blood. Therefore, the mixed oxygenated blood circulates throughout the neonate. And that circumstance, of course, results in poor oxygenation of the tissues in the neonate, and further acidosis and further acidemia. And there becomes a cycle a vicious cycle of worsening hypoxemia, hypercarbia, acidemia, and worsening pulmonary vascular constriction. And since all the air is coming in, instead of the placenta being there, the neonate then becomes more and more in distress. There's a way around that. The extracorporeal membranous oxygenation, ECMO, can bypass the lungs for a period of time. That's a morbid procedure. Canalization has to occur. Bypassing the lung, of the carotids and bypassing the lung has to occur. But in this circumstance, the lungs can be bypassed by oxygenating from another extracorporeal location, and the lungs have a chance to heal. The inflammatory response reduces. The fetus then can decrease its pulmonary vascular resistance for that reason as the damage is healed, and as the fetus then begins to perfuse its lungs better, the extra lungs outside the fetus can be discontinued. So let's review. In the neonatal circulation, there's a transition. Those shunts that occur in the fetus are turned into ligaments, and here are the correlations. The ligamentum arteriosus was the ductus arteriosus. The ligamentum venosus was the ductus venosus. And ligamentum teres is the portion of the umbilical vein. The fossa ovale is the communication between the two atria that flap together and ultimately close. And finally, the umbilical arteries that course downward through the internal iliacs across the dome of the bladder, where the vesicular artery in us generally terminates, and then up the inside of the anterior abdominal wall on either side of the urachus. Those ligaments are called the medial ligaments of the abdominal wall. Remember, the median ligament of the abdominal wall is the urachus. Thank you.